So, good morning, everyone, and without much delay, we'll start today's presentation. um, Being the 26th of January, thank you all for joining on the holiday and the Happy Republic Day. As we know, today is the day we commemorate for when the Constitution came into effect. So, Happy Republic Day to everyone. Um, So I thought in a journal club presentation, we may first want to just um, learn about how to critically appraise an article and how to use it in a clinical context. There are many references, many publications on how to do this well. I just took in one BMJ article, which was published sometime in 2013 about uh, how to critically appraise a journal uh, article. And we usually start off with an introduction of why we have to select a paper. This is usually the reason either to improve our knowledge or to see if there's a clinical question we need to answer within our own clinical practice, and then see what things can be done better, the general reasons. When we are starting off, it's always better to not uh, go through the abstract before the actual appraisal, which may actually deviate the way in which we think about, because results and the authors' ideas are already have come forward. So we can start off with who wrote the paper, the author's affiliations, have they done previous researches, and what sort of credentials these authors have got, uh, as well as the journal where it is actually published. Journals are also graded. The grading of journals only came up in early or 2010 to 15, but the grading system and the impact factors for the journal, which essentially tells how relevant it has been, and how well recognized these journal articles are, is seen. Then we need to look at the analyze the question which have been asked in these particular uh, articles, the relevance to the population which they're looking at, what is the intervention, and how have they used the controls in their study, as well as what the outcome is, and is there a clinical relevance for the outcome. And this is about only the question which has been asked, and then it follows on to see, and is there an available evidence, and what has led to this question, and how relevant the article is, or the study is, to the clinical context of where the study is being done. Then you have to look into the study design. Is it appropriate? What sort of design has been used? For example, a randomized controlled study, which is one of the best ways in which evidence is accumulated, to observational studies, or even single case series. And we need to look at what sort of studies has been published or written up as an article. The population, which will tell us about the generalizability, and very rarely, if you have a specific group or a specific race or an ethnic group which has been studied, you can use the results for generalizability. So this design has to be looked at. Bias can happen either from the person doing the study or the observer, and randomization methods can minimize this bias. Has to be looked at. And finally, looking at the inclusion, the exclusion criteria will always help in uh, um, seeing which patients we can potentially, the study has been considering, and which patients have not been removed. Most of the studies remove the pregnant patients, so it's very difficult to get enough evidence for this, as an example. Then the actual processes have to be looked at. The approach to a study, whether it has been very diligent, has the processes been consistent throughout, and with the statistical methods, there's so many methods, and as clinicians, sometimes we may start getting confused between these methods. But many times these methods are actually pre-published, which will be a better study, and the finally the outcome, has it been appropriately discussed, has to be looked at when we reading these papers. Then it comes to the clarity of the results and the accuracy, comparing with what has been documented in the written text to that of the graphs and tables have to be looked at. The discussion is about interpretation, and do the authors actually have conclusions which they are appropriate to the results they have found. We need to make sure that there is clinical significance, and I mean, have they mentioned about statistical versus clinical significance, and the strengths and limitations of the study. And for ourselves, we must look at whether this whole reading is going to change our clinical practice, and is it actually going to give us any further questions, or we can write to these authors, which may be good for both the students as well as the teams who want to do more publications. So it gives a way in which they'll be able to write up, give them some by writing questions, or to the author themselves. So saying that just as an introduction to the Journal Club for 2023, I'd like to start off with a simple example and with some clinical relevance. This is oxygen saturation targets for critically ill adults receiving mechanical ventilation, was published in the New England Journal of Medicine in 2022 October, and the study is done by a group of people from university hospital, mainly the Veteran Affairs Hospital in the US, Tennessee. It's Nashville there. So why did I select this paper? Because it is a common procedure, and the recent problems of having with COVID and the oxygen dearth situation, and a clinically relevant question about is there a target which we actually use. We know from theoretical models, and I mean, it's a general thing, and the previous studies about having a saturation above 90 is okay, but will it actually bring in outcomes, clinical outcomes, is a relevant question to ask. From the author's point of view, I personally do not know the credentiality of the authors, but this is a Veteran Affairs institution, and some of the my colleagues over here who may be from the United States might know more about the authors. But it has been published in New England Journal, which has a very high impact factor. Any impact factor more than 10 is considered very good. This has an impact factor of almost 176. It's one of the top medical journals in general medicine category. So it's a good thing to read through. So let's go one by one in this article. High saturation targets, what is known from the hypothesis analysis. High saturation targets of 96 to 100% provides the safety. I have made a lot of color coding. Green usually means it's a good thing. Risks and complications, or something which brings attention to my mind for caution, is in red, and the blue are the highlights of what has been seen in this. So risk, higher saturations provide a good safety margin, but it does have risks of oxidative damage, inflammation, and alveolar capillary permeability increase in and many of these studies are quite old. which essentially was trying to find um, the problems with high oxygenation between 1982 to 1999, 98 were these many of these studies. The lower saturation targets a little bit later on um, uh, did risk of uh, uh, show that there's a risk of hypoxemia, but it does not bring in the risk of complications from hyperoxia. And these studies were somewhere between 2008 to 2014. And the intermediate target um, the the intermediate targets were between 94 and 98% saturations. Either of them, there are some of them who fall into the lower category during the period may have risk of hypoxemia, and vice versa when they go into hyperoxia. So this went into the little bit later on studies almost a decade ago. There have been many outcome studies, which is of more interest for the last couple of decades, where clinical outcomes are seen rather than the pathophysiological effects. And but most of the studies in the outcome was for high versus low, and published in 2020s and 21s. There was a very large observational study which showed a U-shaped association between saturations of high and low. The high and the low are not the best, so they concluded that it may be somewhere in between, might be the best. So we do not really have targets of what is of outcome benefit, which has been directly looked at, and so this becomes an important clinical question. And, looking at the study design itself, I felt the study design is, mentioned that it is pragmatic, cluster randomized and cluster crossover, something which was very interesting to me, and how they've done it. They looked at all patients who were mechanical ventilated, and randomization from emergency departments as well as in the intensive care, or where the source has been of the patient. Pulse oximeter was used, and I think that is of huge relevance to how we manage our patients. Three groups were with the saturation targets of 90, approximately 90, that is a range from 88 to 92, whereas the the group with the lower targets, the intermediate target was 94% means, that is between 92 and 96% was the range, and high saturation target group was from 96 to 100% saturations, or a 98% means. And if there was a problem with either the probe for whatever reasons, or there was some suspicion of accuracy, they did use arterial blood gases of 60, 70, and 110 respectively. The primary outcome was more about ventilator-free days, that is days alive ventilator-free, up to day 28. And the secondary outcomes was death by day 28. And one thing was, it was an unblinded trial, so that is of, and I need to remember that it's unblinded. Sorry. Okay, continuing with the study design, they took patients from emergency as well as intensive care, and this randomization, what it means is, cluster randomized is, they took all the patients who were admitted during a month into a particular target group, whether it's um, the low, intermediate, or the high targets, and then they crossed it over. And when the cluster crossover was when they changed the targets from one month to the other, and this was computer generated random targets, and the whole group for the next month was taken into the next targets. And the period, last 7-day period, was considered as a washout period, when they where probably it's like a changeover from one group to the other, and no new patients were admitted into the into the study or randomized into the study despite being admitted. And they excluded all COVID patients. Pregnancy and patients who were in the hospital when they were actually having some symptoms were not used for randomization. They did give a 2-month break during the peak of COVID between April and May 2020. Um, um, the one good thing I found during the study design is they enrolled more there. They had decided to enroll the patients within 15 minutes of initiation. Yeah, and hence many of the patients in emergency did get enrolled. And they did mention that if the clinician or the patient or even a family member um, feels that they need to modify the targets, they would be modifying the target, which I was not very sure how well a study that will end up being. I mentioned about the analytical washout periods, and following the analytical washout period, despite data being continued for patients who have been already randomized or included, the next month they would actually change to a different targets based upon the clinician's preferences. Again, this may end up having problems with the results, is what I thought. How was the study done? The study protocol, I mean, initially they published the protocols and analysis almost a year before the study was done in BMJ. It was a different journal where they published it. Again, BMJ has been considered as a good medical journal. They did estimate the power. I've not spoken too much about the statistical analysis. It's quite a challenging thing to understand from a clinician's perspective. But power calculation is important to estimate uh, uh, the robustness of the study, to see how many patients are actually involved, and at the end of the day whether all of these have been enrolled, to see that the study has been the design has been well done. So they did look at 2000 patients. Enrollment was required for a two-sided alpha level of 0.05. That is the p-value of less than 0.05. When it says two-sided alpha, that means both in the positive direction as well as the negative. That means the intervention is making a difference, or comparable, it's causing harm, is how it's looked at. And the absolute difference of 2 ventilator days between any of the two groups was considered necessary, and this required 2,500 patients. This is a repeat statement, but at the same time I found that 2,541 patients were enrolled, so they completed the actual randomization. Just quite a pretty good number, I would say. In results, we spoke about the total number of patients. Dilip?
Yeah, Shashi, good morning. Thanks for taking it so far. Usually in a journal club format, I think what we could potentially do is, before we get to results, just maybe wanted to delve on a few minutes on what the summary so far is. Like you said, right? Your initial slide. Why was the study done? And do we need to see how the study is actually going to be applicable to our setting? I think you have consolidated that. I think it is a practical study, although you could make an argument, why would such a study get funded? Because, for example, if you look at the ICU ROCKS data that the New Zealand study had, and if you look at a couple of other older studies that looked at oxygen targets, many clinicians would say that we have enough data to avoid hyperoxia. So the standard practice so far would be that don't avoid a saturation of say 99% or 100%. Keep the saturations in the 95% range to 98% range. That's one statement that clinicians would make. The second statement what clinicians would make is avoid oxygen levels less than 88. And I think there's considerable data for that as well. So one could question that why are they using US tax dollars? Because this is a VA funded trial by NLSBI and other entities to essentially redo what has been done before in various settings. So I think sometimes when we are looking at studies, we have to question the utility of a study where enough data exists. Like, are you trying to be a perfectionist to get the data, or do you have enough to just say that, shoot for a saturation target of 95 to 96? So I would, in my mind, I would question the actual reason to conduct the study given the data we already have. And happy to be corrected on that, but I think that is something to be said, and I'll reiterate that point in a minute. The second thing that I wanted to draw attention to all our clinical team members is the point of MCID, minimally clinically important difference, or clinically important difference. This is the point you mentioned about the ventilator-free days. Why is one ventilator-free day not important enough? Why did they choose 2 ventilator-free days as a relevant difference? And this is really important. Anytime you design a study, you want to know what is an important endpoint and how you make the cutoff. So there are 2 ways to do this. One is you can anchor it based on something that you already know. And the second one is you can do it by a distribution. That is, if you look at the bell curve and you say that most studies had a difference of 1.8 ventilator-free days, therefore we'll take 2 standard deviations outside it and look at it as important. Or you can use older studies. So I think in this paper, they used older studies like the ICU Rock study, I think they used the fluids and catheters trial, reference number 43 and 44, reference number 22. They looked at old data. This is the anchoring methodology. So they anchored it to old data where similar studies have shown a ventilator-free day of around 2 days, and so it was deemed that this is clinically meaningful, either from a cost standpoint or a patient outcome standpoint. So remember, when you look at study endpoints, it's extremely important because you can pick an endpoint that is not clinically relevant and still have a positive study. So for example, they could choose that if the difference in ventilator-free days is 0.5 days, they could easily get a positive trial outcome. So just looking at the p-value is not enough. In this, it's extremely important to see if your meaningful outcome is valuable to you, to the clinician. You can have statistically important differences that are clinically irrelevant. And this study, I think, is an important one where I feel that potentially the clinical endpoint and the statistical endpoint may not be relevant because we already have data that this methodology is safe. So again, when you analyze these types of trials, it's important. I'll give you an example from the pulmonary literature. If you're looking at IPF, idiopathic pulmonary fibrosis treatment outcomes, they are looking at mortality, which is fine, but they will also look at how many liters of your FVC have been saved by this drug that you're using for IPF. So then they'll use a cutoff. Is it 100 ml of FVC, 150 ml? And that's where the minimally important clinical difference comes into play. So I think before I look at results, I often spend a lot of time understanding what the authors were trying to test, why they were trying to test it, and what endpoint they used, so that I want to understand, is that endpoint important to the rest of the population or my treating population as well. So I would say that, yes, I think the MCID or CID of 2 ventilator-free days is important, from various angles in India. And if they meet that threshold, I think that's a great outcome because I don't think we always need mortality. So I think just in a journal club format, before getting into results, I usually pause here just to understand whether what the point of the study is and the methodology is, and whether the methodology is applicable to my patients and our practice. Thanks.
Agree. Thanks, Dilip. And yes, there are some of these which you mentioned apart from the why Veterans Association have done this in as I explain and look at what the results are. But thank you for that elaborate explanation. Akila, you had something to say.
Yeah, I think I agree with Dilip that we should look at the clinical relevance of the paper before we really start saying, okay, it's statistically value. But here's the thing: if you go to the breakdowns between the three separate targets, the first target I agree completely. I think clinically we've kind of said, okay, you don't need the 99-100% target. I agree with that. I think there was a lot of squabbling between a lot of clinicians do accept 88 to 92 as a target, but they do it with some degree of reservation in the back of their mind, saying, uh, "Is it really as good as 94, 96%, between 94 and 96%?" So that to me, I think was the main target of this study. Although they put in the upper limit issue, the upper target, but I think they were really trying to do that. I think from a clinical standpoint, I think it does help to the degree that if you have 88% saturation, is that really hurting your patient? Is I think a lot of clinicians were in doubt, and I think that's where I think this study does kind of poke at it. The other thing is that this washout period to me was a little problematic. You know, either you're doing it or you're not, but having a washout period kind of really says you may be doing a little bit of cherry picking of your patients. The other part of this was when they re-enrolled the patients into another group, that crossover part, this clinician having input or family having input on that crossover was bothersome to me because is the clinician going to select the lower end? Maybe not. The upper end, maybe not, but the middle part maybe selected more often. So again, it's a problematic issue for me. They kind of glossed it, they kind of just said it, but again, that reassignment business, that crossover part concerned me. The other thing that I also concerned me was when you have a power analysis that says 2,500 patients, yet you went up to 3,200 and excluded 448. That's 15%. Any study that excludes more than 10% raises red flags for me because I'm looking at exclusion. Why are they excluding? What's going on? What are we not seeing that the reviewers are seeing? Yes, it's an NIH funded study. It's wonderful, great. It's at Vanderbilt. It's at one place. It is not at multiple places. It's at one place. So when you talk about applicability to our patients, we have to be a little careful here. Again, I think that there is, yes, it's published in the New England Journal, but New England Journal is not gospel to me. They're the guys who said the tight glucose control. This is the same group. Tight glucose control was published in New England Journal in 2000. The same journal that also published corticosteroids are wonderful in all sepsis patients, which subsequently turned out not to be the case. So please take it with a grain of salt. I mean, yes, we value the New England Journal. We value the high rating it gets, but it's not gospel. And what I always look at, and like Dilip said, I want to reiterate to everybody is look at how the study was done, where it was done, how it was done, and then tell me, okay, do we think it was done properly? Number one. Number two, was it selecting the population appropriately? I mean, it seemed like they were including everybody, but then why did they exclude this many people? You excluded 15%. You finished up with an 85% evaluation. So it makes you question the conclusions a little bit. You have to be a little careful here. Um, and that's something that, I always like to look at.
Yeah, I agree with Killer. The thing here was that I was just like you said, right? Do we need the three breakpoints? I would think that I would want a more extreme separation so that I can actually test the hypothesis of high versus low oxygen more accurately. So, for example, maybe choosing an endpoint of 95 to 98 versus 85 to 88 would actually be more, clinically meaningful, much more hard hitting. Their sample size calculation would have been easier. They wouldn't have to waste resources to test. The more finer you get, the less relevant it becomes, because how many of you have titrated in that finer range at the bedside? Like, have you ever titrated 92 to 95, or have you ever titrated 95 to 100? It's unlikely. Many of you would be like, if it's above 90, it's fine. So then let's test, above 95 group and perhaps the below 88 group. That might be a more stronger signal and simply more practical. So just by reading the methods, I would go back and think, like, are these methods something I would think about? And if I'm not going to think about it, then I'm going to analyze the paper from that lens. So that's the point I think we are trying to reiterate, and it's a good way to think about studies. And I think just Shashi had briefly mentioned this. There's a pocket manual on how to appraise clinical studies by Gordon Guyat. Gordon Guyat is the guy who did all the studies on the coagulopathy, blood thinner use, and actually leads a lot of trials in the DVT and PE treatment and prophylaxis literature. So that is a great resource for those of you interested in reviewing journals and understanding how the literature is framed out.
Oh, thank you, Akila. And yes, many of, again, as we go forward, look at how the analysis of this has been done by, and some of what Akila and Dilip mentioned will come up in the next few slides along the results, because the results have to be taken with caution, and whether we actually use it or not is how I've looked at it. But there were a few more things in terms of the exact power calculation, the exclusion of the 300 people, which is very important, Akila. Thank you. So again, going back to the results, there were 2,500 patients who were in 41 patients enrolled, and I agree that why did they do it more than what the power calculation actually mentioned, and the 7-day analytical washout period has always been a question mark in my mind, which was read in the one of the other slides. But when they enrolled as per whatever the design was. That was pre-designed, defined washout period, and as you can see, 3,024 patients were enrolled. Some of the exclusion criteria was because they've not mentioned it, but I think there is some mention about one or two things. Let me get back to that in a minute or so. One good thing is they could enroll these patients in emergency within 5 minutes of getting mechanically ventilated. And again, it is more about the robustness of the study and of how they essentially did it. And they did not, some of the patients who were excluded included the patients who were ventilated at the place of residence and who came into the hospital ventilated, but for exacerbation or anything. This was not really mentioned in the methodology. No, I did not get the exact numbers in this particular instance. Next few slides go through the actual results where we have the baseline characters were quite similar. The mean was used. We know that the mean brings in more accuracy to the central tendency or the overall tendency of what the saturations were used, but the medians were 94, 95, and 97% respectively. The there was some problems with the saturations which were either very low or very high in these groups. The low saturation target and patients who were enrolled in the low saturation target had very high, 12.3% of them were saturating 99 to 100% at times, and similarly the intermediate was 14.7% and 32%. How this is going to actually affect the results is something which if anyone can explain, that would be great. But I can see that when they were targeting low, more patients did not reach the hyperoxia, is what I can see here. And those who went into hypoxia, that is less than 85% was their definition, was again similar. And so most of the time there was effort taken to keep the patients adequately oxygenated, which is the ethical thing to do. But there's not much a difference in the ventilator-free days. That is 2 days of ventilator-free difference is what we were looking at. In hospital death was also similar. It's quite interesting to see that these patients who were ventilated had a 34%, almost a 30 to 35% death rate. They have not mentioned anything about the severity of illness. However, I would assume that mechanically ventilated patients having a mortality of 34 is quite high, unless the Apache scores are very high. But this is a in-hospital death and not a ICU death only. Safety outcomes in all the three groups, the incidence of cardiac arrest or arrhythmia, strokes, or complications of ventilation remained similar. Only one patient had a significant bradycardia. They were not mentioned. This is the one in the low saturation group. But what happened to this patient has not been mentioned, which would have been an interesting, whether it went into the cardiac arrest and died, or it goes into the primary outcome that patient did survive. A wordy slide, but looking through this individually, I did not find any major difference in the baseline characters of these patients. It was interesting to know from the results that most of the patients, the difference could be maintained in terms of saturations in the upper part of upper graph. Only for them about day 4 or day 5 is when patients usually start getting better when they're ventilated, even and the intermediate and the lower saturation targets started reaching becoming normal, that is around 95 to 97% saturations. Sorry, Dilip. I'll just finish the slide and then you can talk. Similarly, the use of FiO2 was almost similar, but they did use much lesser oxygens, which I thought is relevant for our clinical practice in between the high, intermediate, or the lower groups. Yes, Dilip.
Yeah, this is a really important slide, because in any trial, once you finish the methodology, when you go to the results, you want to see if the investigators actually did what they promised they would do, which is, was there adequate separation in the targets and the treatment modality? So you will see this in, let's say, a MAP target for NORAD titration. One target will be 70 and the other one will be 60, but if there's a lot of overlap, then the study didn't actually do what they were supposed to do. So in this case, they actually did. But the point that we were making, look at the separation, right? It is essentially 94 to 97 in the three groups. Is this really what you are looking for when you actually read the title of the study? So perhaps the title of this study is there a difference between 97 and 94, or are you looking at a cost saving because you used lesser oxygen? Perhaps that is one way to look at a potential outcome. But this is extremely important. In the lower SpO2 target, was it really lower SpO2 that was tested? I'm not so sure if you look at this graph. So I would pay attention to this before jumping to conclusions and saying 90 and 88 is safe. If you look at it, they never really tested that lower target.
Yeah. Yeah, I mean, although there is a separation, but I mean, even the previous studies, when I looked through some of those literature, even the ICU rock study was anywhere between 95 to 97% as the difference, despite them doing the 90 and the 97 as the difference. So maybe this should have given some answers, but it really did not give the whole difference, is what I'm seeing.
And I suspect this is a human element. Like Akela was saying, this is a human element where no matter how tight the protocol, the physician or the nurse or the respiratory therapist doing this would maybe they deviated from the protocol methodology because they're concerned: is 98 is 90 safe, is 88 safe? These human biases creep up, right? And because these human biases creep up, you may not actually see the outcome that you want to see. Until you dial down the target and make sure that the graph is actually showing what you wanted to show.
And I presume it is very difficult to get away with that bias. And this was an unblinded study, so I suppose that is how we may not be able to get that evidence at all, unless you target much lower saturations and see its safety margin to a 95%.
Yeah, so you need to do it at a smaller scale, because see, to me, this is the point behind wasting tax dollars. They should have terminated the study on can you go back to the previous graph? Yeah, so just zoom in here. You have day 5 or something like that, right? When they were evaluating these patients, by the time they recruited their 800th patient, let's say, they should have stopped the study if they've not gotten enough saturation difference. They would have saved money. They would have been able to re-engineer the trial to actually do something relevant. Here, they recruited all the 2,000 patients till, they would have had a signal that it's not separating. So my judgment here would be like, why do a study when you're going to come up with nothing? And you're not going to come up with anything useful.
Yeah, fair enough. I mean, if it's more, if you look at the study itself, probably it was well done, but its clinical relevance is being questioned more and more as we go along. Yeah. So anyway, they have interpreted that there was no difference between the 3 groups, and in terms of ventilated free days or the mortality, and their interpretation was that it does not prevent death or expedite liberation if you target lower groups. But my interpretation is it may be safer to use lower targets, but again, with all the questions which has arisen over the discussion period, we may have to rethink of it. But generally, the lower targets is never going to be less than 90% anyway, or 88 to 90% anyway. So that's the only thing I could get out of this particular study in terms of how it has been done. The author's conclusions were that it was one of the largest number of patients. Yes, they did achieve it. Again, was it necessary is questionable. And they have mentioned about that only 1% was excluded, but as Akela pointed out, there were about 15% exclusion. Some of them were patients who came from home ventilated, but not mentioned in the study design. They have collected a granular data every minute rather than all the previous studies, which was 6 to 12 hours apart. I'm not entirely sure that, I mean, as previously mentioned by Dr. Chandrasekhar, it is only for that organization. It just tells the applicability or the strength of the organization, how it's running in terms of generalizability. But having a granular data, how is it is useful for um, uh, from my point of view, I don't think it makes a huge difference. Neither does it make a huge difference in the robustness of the results, is what I would say. If you collect it every minute or every 5 minutes or 1 hour, obviously collecting it every minute might be easier nowadays with more and more um, digital data being available compared to what it was in 1980s or even in the early 2000s. So that's the only take I'm taking from their strengths which they are looking at. And coming to their limitations, they have acknowledged the fact that it is no, they haven't done a cost analysis, or it's not mentioned in this unless there is some mention in the supplementaries. But Dilip, cost analysis is how I looked at this particular study. Wait in a minute. Um, the limitations mentioned has been about it helps for strengthening their internal validity, and they have mentioned about the trial being unblinded to both patients and clinicians. However, other limitations which I highlighted earlier, such as patients, families could change it, and was a major thing according to me. That is probably a huge limitation in how studies needs to be done. My take is it is single center, so very cautious in how we really use it in our clinical context. And as I mentioned, blinding is very difficult because at the end of the day, saturations targets, no matter whether the clinician or the respiratory therapist, whoever it is, the physician, intensivist, um, will be unable to manage patients ethically if you completely blind them from what the saturation targets are going to be. So it again becomes a way in which we work with these results. Yes, uh, Dr. Chandrasekhar.
Yeah, I mean, I agree. I mean, I think that these results make it very difficult. I really do wish, like Dilip said, I wish they would have made the separations a little wider. It would certainly have helped for me to be able to say, okay, I can use this. And I can apply it to my patients, even though it's a single center trial from Vanderbilt, which is in the middle of Tennessee. You know, so what does that mean to me? To be frank, I'm going to continue to do what I would recommend, which is target about 94% and sit there. You know, I'm still not comfortable with the 88%, no more than I was before I read this paper. If they would have done something and made it like between 85 to 90%, that would have made my life a lot easier, because then if they were able to show this, and the crossovers are very concerning to me. I'm not comfortable the way they cross things over, and again, that was the problem, and I didn't care for how they did that. So I mean, like I said, it's an interesting paper. Not sure that it really contributes to how we manage our patients.
Agree. I agree.
Why did they do the crossover? Why did they do the crossover, Shashi? Did they present a rationale? I don't remember
No,
reading that.
they don't. See, what they do is they when it comes to the analytical washout period, they did not enroll patients. This is probably for the run. I don't know why exactly they did this 7-day washout period, but it's probably to change the whole way in which the system works, to change it to the next target after a few days.
Yeah,
Uh,
I mean
but
the
when they
duration,
cross
and
to
I'm fine with the duration because oxygen as a drug, all of those washout concepts, I'm fine with that. I'm just like why did they do it? What was it to just
No, it's
save
not
on
mentioned.
recruitment targets, or?
It's not mentioned. The crossover from after, say, if suppose this month a patient is enrolled for low saturation targets, and then he moves on to the next month when the target for the whole um, cohort has been changed to an intermediate or a high saturation target. The clinician could choose whether he's going to remain in the low target for this particular patient, or he's going to go to the high or the for the
Yeah,
new
but
target. They have not
oxygen.
mentioned why.
Yeah, but oxygen requiring diseases are different diseases in 7 days, right? A lot changes. So
Okay.
I'm not. Yeah,
Uh,
hi, Lokesh.
if I can comment, I think the crossover was not at the level of patient. The crossover was the level of cluster. There were
Yeah,
two units in the
there was
same
a
hospital. One was in ER, one was in ICU. So for 2 months, ICU managed a set of targets, and after
no,
two
no,
months,
no. The
crossover.
ICU and the ER cluster together was considered as a particular for a particular target for a particular month. It was
The
together.
crossover happened between the clusters after every 2 months, isn't it?
Okay, not in the patient level, right?
No,
Not at the
Fine.
patient level,
at the cluster
but
level.
at the patient level, the clinician could choose what targets he is going to use, whether it's going
I
to be
got that.
continuing of the previous one or change target.
Yeah, yeah, yeah.
So
Got it.
that is going to bring in a results deviation. So how it will bring in statistically, I'm not sure, but clinically, I'm sure that will change. If
Okay,
someone is
got it. Yeah,
saturating, if they're targeting 98%, and all of a sudden they change it to 90% the next time.
sure.
So anyway, these were my final takeaways. The only thing I could take away from this whole thing, as mentioned by everyone until now, is we may, in our clinical context of lower resources, sometimes it is okay to target lower. But as Akela mentions, I would not go less than 90 anyway. And one ventilated day or minute will cost about 40 to 60 liters of oxygen in any during ventilation, which is a huge amount, and we have just gone through a crisis a couple of years ago. And I just extrapolating this data to my clinical practice directly, no matter what has been shown based on the what has been discussed, cannot be done very easily, because the place where I work may not be exactly like what where the study has been done, and the robustness of the healthcare system and processes has to be looked into. So replication is very difficult. This is all I could take away from the whole study. So as mentioned by during the discussion by Dr. Akela, Dilip, Lokesh, everyone, I think we must be very cautious when reading journals, no matter how strong the journal is, where it's come from, etc., and not take it at face value all the time. Understanding a journal is very important, and looking at our clinical context and having a deliberation of within our own organizations, whether this is going to be used, or how will it change a clinical practice, may make more sense. So that's where I would want to conclude. Any more discussions? It's open, and any more comments or questions, please go in. Oh, I got couple of more things here. Yeah. Yes, Anath.
Yeah, hi. Just comparing to the ICU logs trial, which is our what to say landmark trial for now. It's almost the same, right? Except that the number is high and the number of ventilator days is different.
Yeah.
Ventilator free days are different. So
Correct.
even ICU logs show that having a low or a high saturation target uh, did not matter much, or there was no difference in either of these parameters, with a little improvement in the ventilator free days.
Yes.
So this has also shown the same points, right?
Yeah, absolutely.
So,
I didn't get anything much different from the ICROCs except that they've separated out into three separate categories, but these categories don't have a huge difference between themselves when you come and look at the results.
yeah. But hyperoxia being toxic was all older trials. That is
Yeah,
something interesting that it is not being shown in the last two trials.
there's no outcome measures for the older trials. It's more theoretical, and I think
Yeah. Okay.
measurement of biomarkers, etc., rather than the actual clinical outcomes.
Okay. Mortality versus ventilator periods. Yeah.
That's correct.
Okay. Thank you.
Any more questions or discussion points? If not, we can stop this. So we'll continue to do a journal club discussion every month, depending upon the month's topic. Next month is going to be cardiovascular system. So usually the last week of the month will be the journal club discussion. Welcome everyone again. Thank you. We can